The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I wanted to do a podcast on a concept that I learned recently called driving pressure. I did a literary search on this, and I ironically found out that the MCRIT podcast had done a podcast on this. So, always go to other podcasts, listen to those. But I really think it's fitting that we try to apply this to the HIMSS environment, see if there's any application to this. Found it very, very interesting. And obviously, you know that I love mechanical ventilation and any new research that's come out. The article that we're going to kind of look at, and I'll post it in the show notes, is called Driving Pressure and Survival in the Acute Respiratory Distress Syndrome Patient. It was done by a doctor named Amato and all of his colleagues. Again, I will put this in the show notes. And so what are we talking about? What is driving pressure? How do we optimize oxygenation in these really tough to oxygenate patients? How do we prevent barotrauma? How do we identify if our patients have a poor compliance, have poor diffusion potential? How do we know if one lung is stronger than the other? How do we know if one lung is able to take more volume than the other? Can we even identify that? How do we identify our potential driving pressure? Driving pressure, guys, is the sum of two things divided. And so if we have our tidal volume and we divide that by our static compliance, our respiratory compliance, that's going to give you our driving pressure. So that really doesn't tell us a lot, right? We obviously know our tidal volume. We know our ranges for tidal volume are 6 to 8 mils per kilo. We know that in 2000, the ARGNet study came along and kind of revolutionized the way we deliver tidal volume. And we've talked about this extensively on other podcasts. I've talked about it in our books. And this is talked about in mainstream medicine now. So it should be no surprise. But what we're finding is that, I should say what the researchers are finding is that 8 mils per kilo, the higher end of normal in the lung protective strategy based on that ARGNet study, is not as good as 7 mils per kilo. And 7 mils per kilo is not as good as 6 mils per kilo as far as protecting that lung. And obviously we have come a long way from 20 years ago. I guess approximately 16 years ago is when they did this study. We've really come a long way from then. So we know that these past tidal volumes of 10 to 12 mils per kilo were huge. And even if you're seeing patients be placed on 8, 9 mils per kilo on a normal lung protective approach, even though it's not as high as 10 to 12, that's still not adequate. That's not matching what the data shows. So our driving pressure, how can we identify this on the fly? Well, we know that our plateau pressure is a significant indicator of compliance. We know that it tells us alveolar health. We know that we should be trending plateau pressures constantly. And one of the things I learned from reading these studies is that you should be trending your plateau pressure, and you should be taking 3 plateau pressures and then averaging those, and just making sure that that the patient is well sedated, that they're not trying to take a breath while you're attempting to check out plateau pressure. Make sure they're not trying to cough. Make sure that you're not having any disconnection. So making sure that everything is working appropriately, trending these plateau pressures, and then taking the average, right? Making sure that you're not getting a false high or a false low. So how do we identify our driving pressure? Our driving pressure is our plateau pressure, and then you subtract your PEEP from that. And we know that a plateau pressure of 30 has kind of been the gold standard, right? We never want our plateau pressures above 30, and we know that we should try to do everything possible to get that plateau pressure down below 30. And I always teach this kind of like A in the ABCs, that we never want to leave airway, and plateau pressure is no different. If plateau pressure is an indication of alveolar health and we have high plateau pressures, we've always been taught to try to reduce those plateau pressures. So whether this is just a simple pathophysiology like a tension pneumothorax where we can just do a chest decompression, or we have to really start looking at, is this an ARDS patient where just simply the pathophysiology, just looking at that, there's nothing we can definitively do right this second to reduce that. So number 2 on that list is always reducing the tidal volume. Tidal volume will always be one of the biggest things that increase your plateau pressure. So that means if you started on a 8 mil per kilo, you would reduce it to 7, reduce it down to 6 until you get that below 30. If you start at 6 mils per kilo, like I recommend, then you would reduce it down to 5 mils per kilo and then down to 4 mils per kilo and stop. There's actually studies, and I believe there's physicians that actually have gone below that in their attempt to reduce plateau pressures. So we know that plateau pressures are the gold standard. But this article is really, really good, and it basically kind of illustrates that maybe plateau pressures, even though a plateau pressure may be below 30, if your driving pressure is greater than 15, that is an indicator of morbidity and mortality. That's an indication that your patient's in trouble. So what are we going to do? How can we look at this? How can we apply this to our clinical practice? Another thing that we have to kind of consider is a patient at 8 mils per kilo, they're going to regulate their CO2 maybe a little bit more efficiently. And that one thing that we always have to consider is 6 mils per kilo, your patients may have an increase in acidosis. But what's worse? Are you going to have a buildup of CO2 and a drop in pH? And are you going to sacrifice that for lung protection? And I think a lot of times it's been proven that we actually live very, very well. We can compensate and we can have a very high CO2 for short periods of time and protect that lung in contrast. We have another thing that we have to consider. If we deliver a tidal volume breath of, let's say, 400 mils, and one lung is damaged or one lung is sicker than the other, how do we know that delivering that breath, that one lung can maybe handle 300 mils and the other lung can only handle 100 mils? And that by delivering that breath, how do we know that that doesn't put excessive pressure on the lung that could only handle 100 mils? Right? That's very difficult for us to identify in the field. If 2 lungs are the same, but the first lung has a lower ability to take that volume, a delivered tidal volume calculated at ideal body weight is still going to cause mechanical stress on that lung that has the poor compliance. So how do we reduce driving pressure? An example, if you have a plateau pressure of 25 and you have a PEEP of 5 on this patient, their driving pressure is 20. And so, as I said, this article illustrates that any driving pressure greater than 15 potentially will lead to ventilator lung injury and a worsening situation. Now, this study was a retrospective look at the data. There was no true meta-analysis. There was never a randomized controlled trial. So this was a retrospective review on actual patient data. And so we don't know if this is going to be the gold standard. We don't know if this is definitive, but I can say that these intensivists, these top intensivists at John Hopkins, I know Scott Weingard, have started using this tool in an attempt to see if this is beneficial. So how do we reduce our driving pressure? How do we get that driving pressure to a point where we're not causing further harm? Is our plateau pressure, is that a more definitive tool? And I know when we look at protocols around the United States, whether you're pre-hospital, whether you're in a hospital setting, plateau pressure is that gold standard. So this is something that is new. This is something that's going to need more studying. But it kind of matches that if we reduce tidal volumes to that lung protection, and we identify that your driving pressures are greater than 15, the only thing you can truly do is to increase your PEEP. Because again, it's your plateau pressure minus PEEP. And so for that patient that has a plateau pressure of 25 and a PEEP of 5, to get that to a driving pressure of 15, you would have to increase the PEEP from 5 to 10, and that would bring the driving pressure down to that 15 range. So if we use a lower tidal volume in an attempt to get that plateau pressure down, right, we can go all the way down to 4 mils per kilo. So the standard protocol is 6 to 8 mils per kilo. If we get that down to 4 mils per kilo, we try to get that plateau pressure down as low as we can. And then we increase our PEEP, which we know is also based on that lung protective strategy. It was also based on that ARDSNet study in 2000, that PEEP FiO2 slide, and I've talked about this on other podcasts, that the lowest amount of FiO2 possible to maintain an SpO2 of 93% is much better. It's much better to use a little bit higher PEEPs than lower PEEPs. And so this is another study that kind of illustrates this. So for this patient, if we reduce our tidal volumes down to 4 mils per kilo, we get that plateau pressure down to 20, 22, and then we increase our PEEP enough to get that driving pressure below 15, then based on this study, again, the study is driving pressure and survival in acute respiratory distress syndrome, then that potentially is going to be more beneficial than just maintaining a plateau pressure less than 30. And obviously, there are times where you may have a plateau pressure of 30, 32. It may be an ARDS patient, and you may have to have a PEEP of 20 on these patients. But again, even though that plateau pressure is greater than 30, because we have 20 a PEEP on, our driving pressure is only 10. So again, whether this is something that is definitive, I think that's yet to be seen. But I find it very, very intriguing. I think this is something we can look at, we can easily do. This is not going to really change our protocol. We already have a protocol to where we can reduce that tidal volume down. We already have a protocol to reduce plateau pressures. We already know we want to leave that below 30. And we already have a protocol where we can increase our PEEP. So we're just kind of shuffling numbers a little bit. It may kind of lead us to be more aggressive with our PEEP management. And I think this is something we should all look at. We should take to our medical directors. Again, I will put this article in the show notes. Remember the show notes, you'll need to go to the FlightBridgeED website, www.flightbridgeed.com. Go to this individual podcast, and underneath the podcast, it'll be in a PDF, and you can actually click on that, download it, and save it. So that's all I have for this podcast. If you have any questions on this, if you want more information, just please email me at eric.bauer@flightbridgeed.com. And I'd love to talk about this more. Until next time, I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.